So it looks like we have everyone to make a start here and talk about what the real matter at hand is, and that is, Phil, that look, if I can just quickly introduce what this is all about, which really stems from when I first met you, indeed, as a patient, and you know, you came to me with really a broad set of different you know, ailments, as it were, and then honing in on that somewhat, we decided to check your test, to check what's called your PSA, which is your prostate-specific antigen.
Mm-hmm.
And from that, we worked out and went down that path of finding out that you had prostate cancer. You know, so Phil, I wonder if from this moment on, then, if I hand over to you and you want to explain your journey through that, and,
yeah,
and I'll come in, and I'm sure Sarah will as well thereafter.
Yeah, cool. Okay. Well, I guess, you know, I've told the story many times. I turned 60 last year, and like, I guess, seems to be a bit of a trait amongst Australian males, I ignored men's health issues quite a lot, and all of a sudden last year I was getting a few warning signs that things weren't quite right. I'd been playing tennis a couple of times a week, but perhaps haven't been looking after myself all that well. I was carrying a fair bit of weight, and then all of a sudden, I guess the first thing that happened to me was my knee suddenly imploded, and I thought, well, it's just an old football injury come back to haunt me. And if you remember, Floyd, I also had trouble with my wrists and shoulders when I came to you, and then all of a sudden the rest of my body started playing up, and I thought, oh, well, everything's coming back to haunt me. And then I went and heard a fellow speak at an old football club reunion, and he told about funny anecdotes and things like that, and then came back and said, look, on a more serious nature, I'd like to tell you all about prostate cancer. And at that stage, my nocturnal habits had changed quite considerably, like getting up 4 or 5 times a night to go to the toilet. And I thought, well, look, okay, I should actually do something about this. And at that stage, I think I came to you, Floyd, and hadn't seen you before, and basically said, look, this is what's happened to my body, but I think I should also have a PSA test. And I think you said, basically, well, you're going to have that done anyhow. Our first consult was, what, about 1 hour and 3/4, I think, so it was fairly thorough. Yeah, so went from there, and obviously found out, one, I had some issues with my PSA count, which led to an ultrasound, and the ultrasound uncovered, you know, an enlarged prostate, and among other things, I also had like a golf ball sized stone in my left kidney, which thank goodness I didn't know was there at the time, because I had no pain from it. Yeah, so one thing led to another. Ultrasound went to CT scans. CT scan led to a biopsy, and I think with the CT scan, Sarah, you might know, there's a scoring system of 1 to 5, 1 being less likely of something sinister and 5 being more likely, and I was really good. I got 5 out of 5. And then that was followed obviously by a biopsy after I'd had my stone removed, but then I had a biopsy on my prostate and had a Gleason score of 7, and surgery was recommended, or treatment was recommended. Actually, Paul Manahar at the time gave me options of surgery or radiation therapy, and in his opinion, he said to me that he thought I should have surgery. The reason being that on day 1, he said, look, you're hit by a bus, but you're in recovery mode immediately. But then he also qualified that statement by saying that he had a bias because he was also a surgeon. So he said, I want you to go and see a radiation therapist. So I did that down at Frankston Private Hospital, and he went through all the side effects and the pros and cons of radiation therapy, but at the end also said to me that he thought surgery was a better option for me based on the fact that I was only 60 and there was a an X percentage chance of prostate cancer re-emerging in 15 years' time with radiation therapy. So we went down the surgery path, and again, the recommendation from Paul at the time was robotic surgery. So he referred me to Declan Murphy at Peter McCallum, and yeah, went there in March and proceeded with surgery.
Just, thanks for that, Phil. That's very helpful to know that journey. And I suppose I must say, Paul Manaher was the urologist who I've actually known from working at Monash, and in the past was good enough at the time to see you pretty quickly, which was helpful.
In fact, it wasn't that quick. It was only about 3 hours late, wasn't it?
Yeah, that's right. That's right. Yeah, I didn't think he had lunch, but obviously, yeah. So that worked out really well in that way, and so yeah, you were able to sort of get into that system. There was some waiting there, and I think you worked on your health, improving your health before the operation as well. So you did your bit as well, Phil, along the way. I recall, you know.
It was fairly limited for a while because, as you know, Floyd, I was fairly, I wasn't particularly mobile.
Yeah.
Had difficulty even walking and getting out of chairs and the like. But through each stage, so first when I had the kidney stone removed, and then obviously I had a spate of infections and things which needed some hospital treatment and the like. But through each stage, my body seemed to improve a bit, and I went from, I guess, post-surgery, they suggested that walking was really good rehabilitation and that I should walk 5 minutes at a time as many times as possible in the first week post-surgery. Well, I'm now up to about 2 hours a day, and well, you know what I was like last year. I wouldn't have been able to walk for 5 minutes, let alone, you know, for an hour or two.
Yeah, yeah, because you were saying, isn't it, you do, how many K a day do you do at the moment, Phil?
12 to 15.
God, there you go.
Yeah.
There you go. So that's enormous, and I suppose coming into spring, it's a great time to do it, isn't it?
Yeah.
So thank you for that.
Yeah, it's great effort.
Yeah, and I've often driven around Jindavik there and seen you walking around. So I reckon you're telling the truth.
But I would imagine, you know, and we've spoken that that not only does it assist to recovery, but I think it also says a lot for mental health. That helps in that that sort of mental health side of facing, you know, any form of illness, particularly a cancerous illness, to get out and walk. And particularly now, you said with spring and the sun is out, and get that sun on your back, and would make a huge difference to your mental health as well.
Yeah, I'd say. Phil, do you want to say a few words that way? Do you think it's helped you?
Yeah. Well, just the fact that I think you're capable of it. I mean, when I saw you on opening day in Jindavik there, Floyd, and I went in, I didn't even realise you'd be there, but I went in to say hello to Towhead, the doctor there, and I mean, his words to me that day, he goes, "Oh, you were so low last year when I saw you, and now you're extremely bright." And I think, well, you could probably attest to that as well. Just in my general well-being and my attitude, I don't think I was in a very good place, but I didn't really realise it at the time. The way I feel now, it's obviously, you know, a big change from where I was at the time.
Yeah, that's wonderful. But what you're saying, Gary, is very true. And I think, yeah, exercise, diet, and sleep, these three things, they sound almost boring to bring up as something, you know, medical almost. But the actual fact is they're such vital things to getting through many issues to do with health matters and life in general. If you can sort of think of those three pillars and keep it at that level, you've done a big job in a big part of your own recovery and your own health, sticking to those pillars. But I wonder if now, thank you for that, Phil. That's been very insightful. I wonder if Sarah, do you want to say a few words about, as a urologist, Sarah Azer is a colleague of Dr. Paul Manaher, who is the urologist that initially saw Phil, and yeah, Sarah's been kind enough to join us today to say a few words. So I might hand over to you now, Sarah. Yeah.
Thank you. Thanks so much for this opportunity. I'll just give you a bit of background about myself. So I work in rooms with Paul Manaher and Scott Donnellan, and I'm also a consultant at Monash Medical Centre. We're based at Casey Hospital in Berwick, and I've just come back from a year in the United Kingdom in Bristol doing a robotic oncology fellowship. So I was fortunate enough to be involved in over 150 cases, and that involved removing prostates and also removing bladders for prostate or bladder cancer. And the reason why I left Australia for a year to do that was to practice on the POMS, get a lot of training, and really be taught by two giants in robot surgery over in the UK that have been doing it for over 10 years. They've done over 1,000 cases each. And, you know, that's the level of training that I wanted to undertake because of how passionate I am about robotic surgery. I just wanted to touch on a few things. And when you hear Phil's story and you read Floyd's article about Phil, what's really important is often men presenting to the GP is the first opportunity that we get to give them a once-over and to really see what's going on with their health. And what Phil highlighted there was that there wasn't just one thing going on. There were a few clues, and he really needed a health workup. And, you know, as urologists, I really see it as an opportunity when a man finally does present to see me to get a quick idea of where he is with his diet, with his bowel habit, with his sleeping patterns, whether he's exercising or not, and what's going on with his overall health. For example, it's, you know, very rare for a doctor to ask a bloke how his erections are going, for example. And believe it or not, erectile dysfunction early on in males can be the first sign of cardiac problems because the blood vessels that supply that function can be blocked or calcified. So GPs will often ask a gentleman how their erectile function is, and the patient might find that a bit odd, but that we use that as a clue of possible underlying health issues such as cardiac disease. So I think what Dr. Gomes's article and Phil's story also highlights is he didn't just focus on the PSA, he also fixed his mental health in preparation for major surgery. He got him exercising again, he got his knees sorted, and he also got his blood pressure under control. And why that's important is all of that is gearing up and training for the big day, which was the robotic surgery. So it's not enough to just diagnose the prostate cancer, but it's all about getting the patient ready mentally and physically to fight that cancer and then recover from it. So that's what I love about Phil's story. He had a lot of different things he had to work on, and there is that anxiety leading up to the surgery and sitting on the waiting list, for example, at a public hospital for robotic surgery. But the way to get through that mentally is to realise you're training for a grand final. So getting that blood pressure down, working on your health, getting your waist size down a bit, all helps the surgeon and it helps the anaesthetist too. So I just wanted to touch on that because that is so important in fighting prostate cancer. And in fact, exercise and healthy diet is the only medically proven way to avoid or deal with prostate cancer. It's the only thing in the literature that we know is of any benefit in prostate cancer. The second thing is I just wanted to talk about PSA because PSA gets a really bad rap in the media. And as Dr. Gomes rightly identified in his workup when he met Phil, he knows that PSA is influenced by a lot of different factors, right? So it's a blood test that goes up and down, and it's reliable to an extent, but there are a lot of things that give you falsely raised PSA. So what Dr. Gomes did is he organised an ultrasound, because the ultrasound let him know if Phil was emptying his bladder properly or not, because if you're holding on to too much wee, that pushes your PSA up. He had a look at the prostate volume on the ultrasound, because a big prostate also pushes your PSA up. He did a urine test to look for infection, because having an infection pushes your PSA up. So because of these factors, a lot of people in the media say, why should we get a PSA test done? It gives men undue anxiety. It gives men false positive results, and then they go through a whole rigmarole with the urologists, and often nothing's found. The thing is that that's the only blood test. That's the only thing we've got to give any sort of clue of early, what we call clinically significant prostate cancer. Now, what do I mean by clinically significant? It means the bloke that's in front of me, is he going to live 10 years or more? And if he is the prostate cancer in his prostate going to affect his lifespan and his quality of life? And as your urologist, that's our job. Our job is to give you all the information you need and give you an idea, if there is prostate cancer there, do I need to worry about it? Or is this something that's not going to affect me in my lifetime? So you mentioned Phil touched on the fact he was only 60. Now, if I looked at all the prostates in all the men that died aged 80 or above, we know 80% of them will have prostate cancer, but they die from other things. The problem is when you find prostate cancer in a 60-year-old, that man's going to live 10 or 20 years. So if that prostate cancer progresses during that time, it is going to affect his water flow, his quality of life. It's going to spread, and he might need treatment that will be more deleterious on the rest of his body. So because Phil was so young, Paul Manahar advised him, this is a clinically significant prostate cancer, you need something done. If he'd been 80 with Gleason 7 prostate cancer, it would have been a different discussion. So why is PSA important? It's important because prostate cancer is silent. You know, Phil had some waterworks problems that had started to show themselves. But in most men, there are no symptoms at all. There's no blood in the urine. They might not even have problems with flow. They might not know their family history, especially if their father died young. So the only weaponry we've got in medicine is PSA. Now, the second weapon that urologists have is examination. And the reason why it's important for the GP to then refer to the urologist is because we've felt a lot of prostates, and it's much easier for us to make a decision or advise you whether your prostate is just big because you've gotten older or whether there's a lump or a bump that we're worried about. And then comes in the third weaponry, which is in the last few years advanced in leaps and bounds, and that is MRI prostate. Now, MRI prostate used to be useless. The pictures were too shady. The radiologist didn't feel confident reporting them, and we couldn't rely on MRI prostate. Now, MRI prostate is essential because we use it before biopsies to give us a guide. It tells us how your bladder looks, how your anatomy in your pelvis looks. It tells us how big the prostate is with far more accuracy than an ultrasound. And it also helps us target lesions that might look suspicious. So when Phil had his MRI, and the reason why he had the MRI based on Medicare indications was a finger test and a PSA that was raised. The question that we asked the radiologist is, are there any areas on this prostate that you think we should target because they are acting suspicious? Okay, so what the radiologist does on the MRI is he has many different phases of the scan, and those phases might include different ways of scanning the prostate, or they might include the use of dye. And without getting too technical, we have a scoring system where we know if a lesion does this on phase 1, this on phase 2, and this on phase 3, it's more or less likely to be harboring cancer cells. So the lesion that Phil told us about was given a score of 5, which means highly suspicious. So what we do on the biopsy is we've got a template and we take biopsies top, middle, bottom on the right side, top, middle, bottom on the left side. And this is on the outside of the prostate where cancer usually starts. And then when there's an MRI that shows us a lesion, we take extra targeted biopsies, exactly where that lesion is on the MRI. We fuse it on ultrasound so that we've got a live idea in the operation where that lesion is, and we take extra biopsies there. So then when you come back to your urologist after your MRI and your biopsy, you've got even more information. You've got your PSA, and usually we've repeated that a couple of times to make sure it's truly raised. You've got your finger test, you've got your MRI and whether or not there are any dodgy areas on that. And then finally, tissue from your body that's been looked at under the microscope and reported. And when that tissue is reported, again, there is a scoring system that doctors use when they report it to tell us how far away are those cells from normal. Are they just a little bit different? Are they starting to stick together? Or are they fused into abnormal sheets of tissue that looks like aggressive prostate cancer? Now, what Phil got was a score of 7. The lowest score you can get is 6, and the highest is 10. So he had a medium risk prostate cancer that he picked up in time, and the surgeon looked at his MRI and said, this cancer is confined to your prostate, it has not spread, we can cure you. Okay, so the next point comes to treatment. Now, a big trial was done called the PROTECT trial, where they said, why don't we look at men that have surgery, men that have radiation, and men that do nothing, follow them for 10 years and see what happens. And what they found at 10 years was that there was no difference in survival benefit or return of cancer. So that is why urologists feel an obligation to provide all men with prostate cancer the opportunity to meet a radiation doctor, because we want you to have all the facts so that it helps you make your decision into what treatment modality suits you. Now, what Phil mentioned was very important. He said that after 10 years, we don't know what happens because the trial only went up to 10 years. And they are going to release a second part of that trial where they follow the men up at 15 and 20 years and see what happened. But when you've got a bloke that's 60 in front of you and you know he's going to live 20 years, the problem with offering him radiation or encouraging him to have radiation is, yes, it might work for 10 years, but what happens after that? The other issue with radiation is once you've played the radiation card, you can't have more radiation. So if you have surgery and then 5 years down the track, your PSA starts coming back up, and we say, okay, there's microscopic prostate cancer that's rearing its head in your pelvis, there's some left behind, we think you need some treatment. Because you haven't had radiation yet, worst case scenario, you could go off and have more radiation, have some radiation. But if you've already had radiation and then it doesn't work and your PSA starts rising, the tissue's already been treated with the radiation. You can't have more. So that is a big deal when you've got a young patient in front of you. And so for that reason, the surgeon really gently might encourage the patient to have definitive treatment with surgery and have the whole prostate removed. So that's, in a nutshell, that's the journey to robotic surgery and how the gentleman gets from, I have a raised PSA, what does this mean, to I've got all the information now, I know my PSA, I know how it looks in my prostate on an image, and I've got my tissue result, I know what this means, whether it's low, medium, or high risk, and I'm going to make a decision about my treatment.
Can I ask 2 questions, please?
Yes, yes.
Okay, one's a general question. The second one relates more to Phil. I'll ask the general question first. So I'm 65 and I have regular PSA checks just by blood testing.
Yes.
Probably every 12 to 18 months. I just make sure I'm going to get all the boxes ticked. Sarah, is that enough for somebody, if they get a clear PSA blood test, they don't need to go any further. They don't need the finger examination, all that sort of stuff as well. Is that a fair assumption?
That's a very good question. And Dr. Gomes will know about the general practitioner guidelines from the Royal College of General Practitioners. And this very discussion came up with the college. So initially, GPs were also offering digital rectal examination. The Royal College of General Practitioners has now advised GPs that they don't have to do a finger examination. But what you will find with GPs is they will ask you about your family history of prostate cancer, and they often are still asking patients whether they would like a rectal examination or not. Now, some GPs don't feel comfortable offering that exam because they're not doing them anyway near as often as they were or as urologists are. So if they hear you have a family history, often they'll say to you, look, your PSA is very low, it's very normal. Would you like to see a urologist to follow up your PSAs or to have a finger examination once a year? So a lot of my patients have normal PSAs, but they will still come in once a year to follow up on the trajectory of that number, because we look at the trend and not just what the individual number is. And then I'll examine them, give them a men's health checkup, talk to them about their waterworks and do an examination. So it is completely up to the patient, but what the research done by the Royal College of GPs found was it was not essential for GPs to offer it, and that PSA monitoring was enough. And then if there were any concerns, they could refer the patient onwards. Now, that being said, unfortunately, because I see a lot of prostate cancer, and previously working at Peter McCallum during my training, you know, you saw all the patients come in for their robot surgery. Yes, I have seen patients with a normal PSA and an abnormal finger test. So that is why urologists always do examinations on male patients, even if they're in for something else. If they're 50 or above, I always do a finger examination, because I have, unfortunately, in my career, incidentally found a lump on a prostate, gone on to do an MRI and found a cancer there. So, you know, my message is discuss it with your GP. And if you have a family history of prostate cancer especially, get a urologist early. Find someone you're comfortable with and see them on the regular, because as you get older, you'll want to discuss other things with that urologist anyway, such as getting up at night or slow flow or even erectile dysfunction. So no harm done. And it's just more reassurance, if it's normal, that you've had 2 tests, tick, tick, both normal, I'm right for another 12 months.
Right, yeah, that's a great answer. Okay, the second one was for Phil, well, not for Phil, but for you in respect to Phil, and Phil might be able to enlighten us on this. Prior to Phil being diagnosed,
yes,
he had massive inflammation in his joints. Now, and then I think also prior to the prostate, well, in the process of that, they found that massive kidney stone.
yes.
Which almost rewrote the record books, apparently. So, so I mean, my question is, are they correlated? Are they related to the prostate? Is the inflammation, was that a telltale sign that something was going on, or was it just a coincidence that he happened to have that kidney stone as well, and that was creating, you know, massive joint inflammation? They put him on steroids. Is that right, Phil? On steroids to try and relieve that a little bit.
Just a trial on steroids for a week to see what the effect was. Yeah.
And Phil, do you have any gout at all?
No. Just on Sarah, just for your background on that one too. When Floyd was treating me and we found out about the cancer, we sort of decided between us that we'd look at one thing at a time. So.
Yes.
I'd had some ultrasounds on shoulders, and I went to a neurologist about my wrist for carpal tunnel tests and things like that.
Yes.
But I never went to a rheumatologist because he thought I may have been suffering from PMR, like polymyalgia rheumatica.
Yes.
Hence the trial on steroids for a week, which is fantastic. But as soon as I went off them, I reverted straight back to the way I was, sort of thing. But then we sort of had this theory, I don't know if there's any substance behind the theory, that maybe my immune system was fighting back and causing all these issues with my body. I don't know whether, if that's something that could happen or not.
Yes. Well, the first thing I would say is that the kidney stone and the prostate cancer are completely unrelated. So that was just an incidental finding, and I'm sure the surgeon would have sent off some pieces of your stone to find out what kind it was. Now, if you don't have gout, that suggests to me you probably don't have high acid or uric acid levels in your blood. So you probably had the most common type of stone, which is a calcium oxalate stone. Now, that being said, when they broke up the stone, you did get a lot of infection. So another possible cause of a large stone in someone like yourself is actually infection stone. Did they ever tell you what kind of stone it was?
Look, I may have something from Monash on that. I'm not too sure.
Yeah.
But yeah, I had, with the infections too, it's because I also had a stent in and there was still some fragments left, and apparently that was all harbouring bacteria. Every time I knocked out the infection, it just reared itself again.
Yes, so it sounds like there was an element of infection stone. So, you know, we do special tests on people like yourself after they've been cleared of stone. We do a 24-hour urine analysis, and we also do some basic bloods. And that's just to try to find something to change in your diet or your lifestyle or your tablets to prevent you making more stone. But 9 times out of 10, the only thing we find in that test is that in a day, in that test, the lady or gentleman only makes, say, 800 ml or a litre of urine, which is not enough. So we want people that make stones to pee out 2 litres of urine in 24 hours. Yeah. So 9 times out of 10, we do all these tests, and all we say to them is, unfortunately, you are a stone former. You've got to drink more water than a normal, you know, than what would normally be expected. I want you to chug 2.5 to 3 litres of fluid a day so that you're peeing 2 litres a day. Now, that being said, what is interesting, and this is theoretical, is when the kidneys are under stress, and obviously having a very large kidney stone puts a lot of pressure on your kidney and a lot of strain on it. That can affect the kidney's ability to filter the nasties out of your blood and excrete it in your urine. So what is interesting, and we'll only know this if it settles down once you're clear of all your stone and things, if your joint inflammation improves, which it sounds like you're still needing some treatment for, there is some theory that unfortunately, because the kidneys are so pivotal in blood pressure control and filtration, is if one is under strain, that might mean you can have more waste products floating around in your blood. And that can include things like uric acid or calcium. And that, as a result, can have some effect on your immune system and your, you know, for example, cause inflammation, an inflammation or infection process, which could manifest itself in your joints. So, you know, if it still continues even after the stone is cleared, then that theory, you know, is dispelled because the pressure is relieved on your kidney and it's functioning normally and it's unblocked. But, you know, having a large kidney stone or significant infection in your kidney can most certainly affect your energy levels and just your overall quality of life. Yeah. But I feel that the you know, there is no correlation between kidney stones and prostate cancer whatsoever. In fact, most men, when they come to see me, are fighting fit. Some of them haven't even had waterworks trouble yet, and it's just incidentally the GP said, I've tacked on this blood test because you're over 50 and it's unfortunately raised.
Right.
Very good. But yeah, but Phil, you're nowhere near. So I remember in reading your article, Floyd, that, you know, when Philip came to see it, and I spent, you know, did a couple of come over and saw Phil, and I remember one day we went to Rotteveel, and Phil was, you know, like, he's 6 years younger than what I am. Yeah. He was walking as though he was 30 years older. Yeah, he was really struggling, and to get out of a chair, even at home, like remember, Phil, you were having to rock, you know, 2 and 3 and 4 times to get some momentum up just to get up out of a chair. So, yeah. But you're not encountering any of that sort of issue.
No, not at all. No,
as much now. So,
yeah, as I said, through each stage, that seems to have improved. I don't know why. Even prior to robotic surgery, Sarah, I was taking an anti-inflammatory just to try and relieve some of the symptoms, and I stopped taking that in preparation for surgery, and I haven't had any medication for the inflammation since.
That's fantastic.
Yeah. Just on the surgery too, for your information, Sarah, robotic surgery. I was at Peter Mac with Declan Murphy, and my surgery was early afternoon at 12:30, 1 o'clock, and back from recovery 7:30 in the evening into my ward, and I was discharged at about 11:15 the next morning, which was amazing. Yeah.
I mean, going over to the UK where the population's so much bigger than here, I mean, they essentially have had to implement robotic surgery because we don't have the room in the hospitals there to keep people 5, 6, 7 days. And the beauty of robotic surgery is, you know, when you book a patient for that surgery, you tell them you'll be in hospital 23 hours. And if it's longer, it's usually because the patient's from the country. And I just don't want them sitting in the car for so long immediately after surgery, so I might just keep them an extra day. Yeah. But, you know, the way I was trained to remove a prostate using open surgery was back-breaking work. I mean, especially if you imagine a big farmer with a big belly to match, you know, that prostate is down deep in the pelvis. And, you know, there is a bone called the pubic symphysis that sits on your pelvis. If you poke your pelvis right now, you'll feel that bone just above the start of the penis. And if that bone is sitting in the way of an open surgeon, you are literally turning your whole body, looking down a dark hole, desperately trying to dissect carefully out this often small gland. And it would take us, you know, often 3-4 hours. Men at times would lose half a litre of blood. And, you know, robotic surgery has changed a difficult operation to one where you have a 3-dimensional camera, a pristine view, and you have not just keyhole instruments that are on sticks, you actually have elbows, you have wrists, you are able to do very fine, delicate maneuvers. Now, why is that important? Well, whenever I meet a man and tell him, you know, I feel he should have his prostate removed, unfortunately, that's going to affect his continence, and that's going to affect his erections. When you have someone that's 50 or 60 and you tell them you're going to need to wear pads for a little while, or we're going to need to put you on tablets for your erections after surgery, that is a huge mental and physical hit. But the reason why that is the case is because this is how the bladder and the prostate look. So the water pipe is actually running straight through the middle of the prostate. So that means to remove that gland, I'm actually having to cut that very important water pipe that then continues down the penis, allows people to go to the toilet. Once that's cut out, I've then got to join that water pipe onto the bladder using very important, delicate stitches. And the reason why men are incontinent afterwards is because we've affected one of the 2 sphincters that close shut and stop a man from leaking. So what Phil had to do before his surgery is build up these muscles in the pelvis. They're called the pelvic floor muscles. And the reason why you've got to build them up is just like a bicep in your arm. If you've not used them for a while, and if they're not built up, they're weak. But we need those muscles to recruit them, to help them squeeze shut the water pipe so that the leaking gets better and better and better months after the surgery. Now, this tube that I've drawn in here, that's the catheter that Phil would have had for about 10 to 14 days after the operation. And I describe that catheter as a splint. So just like when in the old days, if you broke your leg out in the bush, they'd strap your leg to a piece of wood so that your leg would heal straight. That's exactly what this catheter is doing for my stitches, my reconstruction of joining the bladder to the water pipe. It's letting the urethra, the water pipe, heal open and straight. And so after 2 weeks, we know those stitches have started to heal, they've done their job, and you're watertight inside. So then we can remove that splint. And I always say to men, the minute that catheter comes out, you are going to stand up and you are going to leak. And that is completely normal. But you've been training for that. You've beefed up your pelvic floors, and you're going to kick back in with your pelvic floor exercises. And you'll go from 3-4 pads a day to less and less and less. And that is a difficult journey, and a bloke has to accept that before I let them have this surgery. They've got to be willing to mentally you know, fight that mountain and trust that the robotic surgery allows us to make a good watertight join and the continence will get back.
But you weren't on pads for all that long though, were you, Phil?
Oh, yeah, 2 to 3 months, 3 months, let's say, maybe.
But you didn't have a lot of leaking though, did you?
No, actually, it was probably 2 months. May, I think by the end of May, I think I stopped using pads. Yeah, and I had surgery mid-March.
And it's because you're not overweight and you did your work beforehand and you were committed to it. You know.
Oh, look, I was overweight. I still am a little bit, but I've lost about 12 or 13 kilos. So.
Very good.
Yeah.
Very good. It all helps.
Yeah.
It all helps. We know that often, you know, when patients are a bit bigger, it's a harder operation and it's harder to heal. So it all does help.
Just for your information too, for Floyd as well, Sarah.
Yeah.
I had my second post-surgical appointment with Peter Mack yesterday.
Right.
I did my second PSA post-surgery about a week before, and PSA was undetectable. So
fantastic! Congratulations. Yeah. So you are cured of your prostate cancer.
At the moment, yes. Another check in 3 months, which is good.
Yes.
Yeah.
And did they tell you about the pathology report on the specimen and that they got it all out and it was Gleason's?
Well, it was a bit dicey actually because when they got it out, they said it was pretty difficult even though it was robotic because it was stage 5 on one side.
Wow.
It was pretty close to the edge and they said, look, by naked eye, it looked okay, but they had to wait for that first PSA test in May to see what had happened. Yep. So I was sort of considering or thinking the worst, of course. So yeah, here we go again, PET scans and, you know, whatever happens after that. But fortunately, it didn't happen. So yeah.
That's good news.
And what they're talking about is when it's right on the edge of the capsule or, you know, the orange peel, imagine like a layer, we call it the capsule that's covering the prostate. If the cancer is going right up to that capsule, we worry that microscopic cells have jumped ship and that they're left behind in the pelvis. And obviously, you'll never see them with the naked eye or with any scans. So the only thing we've got to monitor that is PSA. So why they're warning you is, you know, in 10 or 12 years down the track, your PSA might start to trickle up, which makes them think, oh, right, so there's something microscopic in the pelvis that's secreting PSA. Now, as we talked about before, even if that happened, you would be a candidate for radiotherapy to burn those cells and kill them off and get your PSA right down. But obviously, because we want your tissue to be intact and healthy and well oxygenated and, you know, it's doing such a beautiful job healing since the surgery, we want to avoid that radiotherapy altogether. And if your PSA is undetectable, then you just don't need it.
Yeah.
That's good.
Yeah, no, I was pretty pleased.
Yeah, very good. Yeah, sounds like you're right. So what decisions did you make about your sexual health and things like that? Did they talk to you about a nerve spare operation and did you have that?
No, nothing at this stage, just a little blue tablet, but, you know, haven't had much action as yet, to be honest.
Yeah, yeah. And you know, I won't go into that in front of your brothers, obviously, but you know, just briefly, you know, that is important. So once men have gotten on top of their continence, that's the next part, and that's the thing the urologist will now focus on. Phil, they'll try to get that back for you and talk to you about all the options for that.
Yeah, there's two things. I mean, even leading up to it, Sarah, there's two quotes, and I think one might have come from Paul, and one came from Declan, and one was, you know, dead men don't have erections and you don't have sex in coffins. So
I mean, I'm not that blunt with my patients, but yes, it is true.
Doesn't hurt.
Yeah, but you know, if I could put that in an eloquent, more feminine way, I would say that the priority is always cancer control, not sexual function, right? Yeah. So if the surgeon's got to pick between your cancer and getting that out, or sparing the nerves so that you have erections more naturally, the priority is oncological or cancer control.
And look, and Declan warned me prior to surgery that because it was rather aggressive on one side, I mean, nerve damage was almost inevitable.
Correct.
Yeah.
Correct. Because it would have been the nerves hug the outside of the prostate and run down to the penis. So we've got to peel them off to do what we call a nerve spare. Now, if the cancer's engulfed those nerves, and then we peel them off, we'd be leaving cancer behind. So when you've got a lesion like that right on the edge, you just go as wide as you can to make sure you've got all of it.
Yeah.
Yeah.
Hey, Phil, I'm going to have to go because I've got to go. I've got an appointment at 11 o'clock down in town. So,
Cool.
but Sarah, fantastic, great information. A bit like Peter, I've had blood tests. Oh, I'm 67. I reckon I've had an annual blood test since I was about 45. So
Perfect.
And touch wood, nothing's occurred. I had a couple of kidney stones at some stage, but yeah.
Yeah. And so you just need to guzzle lots of water too. But what's interesting?
Yeah, I try and drink a couple of litres a day, but sometimes the bottle of red gets in the way, but that's okay.
Yeah, that's all right. It all counts. But what's interesting, you know, since we've got all the brothers on the line just briefly, is that tissue that Peter Mac obtained, removing that prostate, they can then do testing on that tissue to look for genes that make people more or less likely to make prostate cancer. For example, we know the BRCA, BRCA gene, which is associated with breast cancer, can manifest in men as prostate cancer. So what they'll do is they'll have a look at Phil's prostate and they'll see if there's any, if that tissue is BRCA gene positive. And if it is, then if the family was interested, sometimes we do genetic testing through companies such as Eugene or even through the Peter MacCallum Familial Cancer Clinic. And we look at all of your gene profiles and tell you whether you're more or less likely to get cancer in your life.
Okay. Well,
so that's, you know, a different side of things. Yeah.
Yeah. All right. And Floyd, thank you for the opportunity. And I've got to go, but well done to everybody. I think it was fantastic, very informative. Yeah. And Phil, keep us in touch with that gene thing too, because it'd be worthwhile following up on that.
No worries.
Cool. All right. Enjoy the rest of the day, everybody.
Thank you.
Thank you.
Thanks, Gary. Thanks for joining.
Bye.
Sarah and Floyd, I just have a little question that came up just with something that Gary just said.
Yes.
Now, and Phil, when I spoke to you early on, I asked you a very pertinent question. I said, well, didn't your GP advise you to have regular tests? And Phil, I think your answer at the time, Phil, was that you actually didn't have a regular GP.
No.
And it just, you know, I'm fairly conscious of my health because I actually, Phil will tell you, I have a lot of osteoarthritis. So, you know, I'm having all my joints operated on, you know, they're queuing up at the moment. 20 years of gymnastics, basically. So I'm very conscious of that, and that affects my mental health too. But the one thing I'm also mindful that and I'm not going to pull a percentage out of thin air, but I reckon there is a very high percentage of men that don't even ever think about getting regular PSA checks or regular blood tests to check all the other bits and pieces at the same time.
Yes.
And you know, is that something that GPs should be doing, irrespective of whether you're a regular patient or not, as an alert when you get to a certain age that you should be advised, or should that be something the government should be doing, or you know?
So that's a really interesting topic you've touched on in public health and in medical health, and we call that screening, right? So just like we've got a bowel cancer screening program where we send out the bowel cancer sample fecal test. So the question that's been raised in the medical literature in Europe and in America, in Australia, is should we have a PSA screening test? And the way that we test whether a screening test should be implemented as compulsory or not is we do big landmark studies. So the big studies that we know of in Europe, you know, had some 24,000 men. And we monitor their PSAs, their annual PSAs, and we look at what would have happened if we had done it annually. Would we have missed the cancer, or would we have saved lives? Now, the number needed to test to save, I think it was 27 lives, was something like 200 or 300 men to save 27. So basically the long and short of all those big trials that have been done in America and Europe was that screening, when you look at how invasive it is and how much it costs the government and all of those, actually did not protect or prevent enough deaths for it to be worthwhile. So that is why Australia does not have a national PSA cancer screening compulsory program. in summary. It's based on research, and they found it's not beneficial enough. So what the Urological Society of Australia and New Zealand did is they released their recommendations for the Australian population and New Zealand population. And what they said is exactly what you have all been doing, which is if people have a first-degree relative, a brother or a dad, who's had prostate cancer, you should be monitoring his PSA earlier. And the new research out of Europe is that even a man's PSA in his 40s, how normal it is or how close to abnormal it is, could be indicative of prostate cancer later in that man's life. So they've recommended people with a first-degree relative do it earlier, 40s or 45 or above. Other men, you can have it done in your 50s, 50 and above. And if you get a normal result, it then says don't do it for another 2 years. It says if you get an abnormal result, repeat it again in 6 to 8 weeks, make sure it's abnormal, then go to a urologist. And they set out the guidelines of what should you do when that man reaches 70 and then over 70. So we felt that we had to release that as a surgical body because the screening tests or papers came out and said no need to screen. So then everyone went, right, I just will stop doing it then. But what we're worried about is that we'll then lose or miss that subset of men that might have a genetic predisposition to prostate cancer and not even know about it, say if they were adopted or if their father died early. And then also there are the rare cases that we pick up in 50-year-olds where their PSA is up and they've got no family history at all, but you feel something or the blood test just comes back as high. So that's basically how we got around those papers that said screening shows no benefit.
But how does that message get out, Sarah? That's probably more my question. How does that message get out? And
Yes.
you know, the Australian macho male who thinks prostate cancer is a weakness.
Yep,
That's
right. That's right. Unfortunately, the only things we've got to get that word out are people like Phil doing their cycle. It's a run, isn't it? You're doing 75K. Is that right?
No, it's 72 Ks over a month, but I knocked that over in a week actually, just walking with the prostate.
Wow. Charities like that and Movember, the whole point of Movember is trying to get men to talk about their health and trying to get them to get into the doctor's surgery. And then Monash Health has decided to get Brian Taylor involved and Eddie Maguire to help us do pedal for prostate cancer. So we're doing a virtual cycle. All the surgeons are hopping on bikes to try to get Twitter and the internet and the media involved. We're all donning our Monash Health prostate cancer riding gear to try to tell men, you know, Monash Health's here for you. Get a referral, talk to your GP about PSA. And then amazing people in the media like Stephen Fry, you know, Sam Neill, all these people that came out and said, I've had a PSA or I've had it done. That's all we've got. Now, GPs that refer regularly to us, like Floyd's rooms, and, you know, other places around Bentley, Warragul, Berwick, those GPs you'll find, and usually they're, you know, male GPs, they have decided to take it upon themselves to offer it to their patients. And they do it as part of their routine workup. And often they'll discover raised PSAs. And what I say to GPs is, if it comes back, even the first one is raised and you don't know what to do, just send them to us. Leave it to us to make the hard decisions and have those hard discussions, because this is what we do all day, every day. But like you said, we still need the men to ask for the test or the GP to bring it up. And what's hard for GPs is men just don't want to go in.
Yeah. Well, I also have to go. So, Phil, fantastic, and just congratulations, and you know, keep going. You know, it's just wonderful. So, Sarah, wonderful, and Floyd, thank you, and
Pleasure.
yeah, hopefully, Sarah, I don't have to see you very soon.
I got my fingers crossed, but you're always welcome.
Okay, thanks, guys.
Thanks.
Thank you.
See you later.
Take care.
Well, look, I think we've covered a lot of ground there. I suppose, Bill, do you want to just quickly tell us a little bit more about the charity that you're involved with, the Long Run, and what that's about? Yeah.
All right. Well, the Prostate Cancer Foundation have got obviously an event running for September. So I guess what their aims would be to raise awareness, research, and also support for people who have prostate cancer and their families. So there's a fundraiser which involves 72 kilometres of walking or running over the month of September, and people can make donations via a profile page, which I obviously have, which you published in your newsletter, Floyd. I also published in the Jindavic newsletter. I don't know if you've seen my article in there, have you at all?
I think I have, yeah.
It was, yeah, just a thing about awareness and whatnot. I've become a bit of an advocate now, like the guy at my football club was also. So I try and use any opportunities I can to tell guys you should get this done if you haven't had it done. Yeah. So basically it's just a fundraiser sponsored or organised by the PCFA for the month of September for those purposes.
Yeah, and it's called the long run, isn't it?
A long run, exactly.
Yeah,
exactly.
But you can run, you can walk,
yeah,
whatever
yeah.
you want to do.
As I said, I walk twice a day at the moment. I generally walk. I do about 5.5 kilometres in the morning and 5.5 to 7 kilometres in the afternoon. And nice brisk walks. I average about between 5.5 and 6 kilometres per hour, I guess. And you know what the hills are like around Jindavic, Floyd?
Yeah, that's right.
But,
Beautiful.
just my general well-being, I feel so much better. Unfortunately, I had to finish work back in September and didn't bother looking again because I knew what was coming up. But I didn't know coronavirus was going to come and impact the employment market so much. So my next thing, obviously, I'm still concentrating on recovery, but I'm too young to retire. I want to try and find some work as well.
Yeah, definitely. Well, look, I mean, you've come so far now. I'm sure you'll be able to get there. Yeah.
And as I said, look, I was pretty stoked with another positive result yesterday.
Yeah.
Do you know Marcus Cumberbatch, Sarah?
Yes, of course.
Yeah, that's who I had an
That's who
appointment
you
with
saw.
yesterday.
Oh, fantastic. Oh, that's great. I mean, you can't get better than Declan Murphy doing your surgery, and you've got an amazing team there. The prostate cancer nurses there are phenomenal, so you're in good hands.
Well, that's another thing that, just to mention, I mean, the support structures, I mean, I was quite surprised, we had information sessions at Peter McCallum. Then, I was referred to the prostate centre in North Melbourne as well with a pelvic physio, and that was really supportive as well.
Yes, and without tooting Monash's horn too much, I will say that we did feel that we needed to provide that for our side of town. So, Peter Mac is so beautifully set up with all of that. And at Monash now, we do have access to some robot cases for public patients, and we're doing them over the road at St John of God Berwick, but still as public patients, which is amazing. And so, the whole point of our fundraiser is we're now trying to increase funding for our biopsy technique for transperineal prostate biopsy and those ultrasound probes that help us do targeted MRI guided biopsies. But then also we've now got we've got pelvic floor training beforehand, prostate cancer nurses on hand to prepare people for surgery. But then we've now put in what's called a survivorship clinic. So that's for following up men after they've come through their surgery, just making sure they're, ticking all the boxes with their continence and their erectile function, and then also their mental health and just coping with this new change to their life after surgery. So, our hope is that for our patients in Warragul, Latrobe, Valley, Berwick, all that catchment, that now they don't have to travel all the way to Peter Mac, and we can do the same closer to home, hopefully.
Yeah. Sure.
You really had that team helping you at the end of the day, isn't it, Phil?
Yeah, for sure. I mean, look, I've been in a lot of different hospitals since October, actually, with various procedures. But I was actually at Monash Berwick for a while, Sarah. With I had I had the rest of my stones knocked out there, but so that was good. Also Monash Moorabbin, where I had the big stone taken out. Actually, you might not know, the day after my surgery on the kidney stone, Sarah, I had sepsis in my bloodstream. I ended up in ICU at Clayton as well. So it wasn't a very good time, was it, Floyd?
Yeah, but you got through it. We checked your urine a few times, but
No, but the whole team, I mean, as I said, Peter Mack was great. Mark Diacera, I think the nurse there, he was really good. And just, you know, with handouts, with the information session, available for phone calls, questions and things like that. Paul was really good through the process too, obviously. Yeah, found him very easy to deal with. And one thing I've mentioned about yourself, Floyd, and also Paul was the same, lot of empathy.
Yeah, it's important. And I have to commend you on your mental attitude as well. You know, you got this news, but you didn't let it defeat you. You went, right, I've got two things I've got to deal with here. I'm going to focus on the kidney stone. And that sounds absolutely horrible. It sounds like you went through the wars with that and you know, a very big stone, but you didn't let it get you down. And you went right on to the next thing, robotic surgery. I've got to get this done. And then I've got to get moving straight away because I've still got my life to live.
Yeah, exactly. Yeah,
you did get on with it, Phil, I must say. And yeah, like you said, because Sarah, Phil had really a lot of joint pain when he could barely, like his brother was saying, get out of the waiting room chair when he first came. So
wow.
Well, I remember you and Toby had to help me out of the chair one time there.
Literally, we had to get him out of the waiting room chair. So, you know, from that to where he is now, it's actually been just such a dramatic change, and a lot of that is from your doing, Phil. So on that note, I must say I was really taken aback when you told me about your charity. It's a little while ago now, maybe about, I don't know, maybe 2 or 3 weeks ago that you let me know. And I thought, well, if you're so brave to one, tell everyone about your your journey through prostate cancer, and then secondly, involve yourself in raising that money, well, we'd like to be a part of that in doing this presentation, and also giving you $500 towards your goal. Because
amazing.
No, look, I think you deserve it, and as I said, you know, I drive around the streets of Drindavik here and there, and I've seen Phil, so I do know he is doing those Ks. He's not just, what should I say, shaking around the pedometer.
Yeah. So, my wife reckons I just do it so I can bump into people and chin wag with them, you see.
Yeah, well, that's as good as a reason as any. So, we're really very happy to support you in that, and hopefully we'll be able to, you know, see you through getting stronger and stronger as you go.
All right, thank you very much. Yeah, thank you.
That's okay, our pleasure, my pleasure. And Sarah, Dr. Azer, what I can say is that description has taught me a lot as a GP. So I'm sure that any patient or interested person who'll watch your presentation will gain a tremendous deal from it. And I really thank you for putting in all that effort to explain everything from that technical standpoint. It's been very helpful to have you as a part of this presentation today. And yeah, look, as you described, Dr. Azer, you're in Berwick and St John of God, you know, through Monash and St John of God. Where else were those hospitals that you're
That's right, yes. Yeah? So Casey Hospital, Monash, St John of God, Berwick. I'm at Holmes Glen Private, and very soon, hopefully, starting down at Latrobe Regional. So that'll be great, because it means I can give my country patients some access to Monash, and you know, hopefully to robotic surgery too. But obviously, as a female urologist, I see a lot of men and women. But you know, the other thing is, and Paul Manaher is exactly the same, and Scott at our rooms is exactly the same. You know, sometimes GPs just call me and just have a quick question, or just want to chat. Or they just want to run something by me, and you know, they don't want to make the patient wait and, you know, put in a referral, but they've got it under control. They just want to check they're doing the right thing. And so we just say to them, just give us a buzz, even call the rooms and just say, look, can one of the urologists call us back? We've just got a tough situation or a tricky case. Even something as simple like with Phil, which one do I deal with first, the stone or the PSA? You know, that's really technical stuff. And, you know, especially with PSA and MRI and that whole discussion, we just say, absolutely happy to see them. Don't worry about any of that. Send the man to see us, or we'll go through all the nitty gritty. But as you said, it's technical stuff, isn't it, Phil? It's a lot. Yeah. You can't rush that consult in 10, 15 minutes, can you?
Actually, Sarah, just to go back, you know, to what Floyd was saying earlier when I came to him, I mean, just, you know, and I joked about, you know, 3-hour wait, and I'm not joking. So I was in Floyd's rooms in Druin, and, you know, we got the ultrasound report back referring me to a urologist, and he says, oh, how's Berwick for you? And I said, oh, yeah, that's no dramas. And it was on a Wednesday, right? And he says, oh, he actually comes to Paul Manahar. I know him from Monash a few years ago, and RRR, and he actually comes to Warragul on Wednesdays. I'll just give him a quick call and, you know, oh, Paul, you know, Floyd here, I've got Phil, da-da-da-da-da. When do you think you can see him? He goes, oh, how about 1:30 this afternoon? So it was amazing. Yeah, it was amazing.
I mean, that's next level service.
Oh, yeah, it's incredible. The gods were shining, I tell you.
Yeah, well, the thing is, if we're in the country and we don't see you that day, then you've got to wait another month till we're down there again. So he just didn't want to leave you like that. So that's Paul Manahar for you. Yeah. We do try to see new referrals within 2 weeks, because it's just not fair on the patients to wait that long. So we always say, if they're a new patient, get them in as quick as possible, because otherwise the GP's waiting to hear what to do and the patient doesn't know what's going on. So sooner the better, I always say.
Yeah.
Yeah, it was very helpful on that day. But yeah, look, I think that what your brother said, Phil, about at the end of the day, you know, men coming forward and sort of stepping up to care about their health along the way. There's a message there. You know, obviously, Sarah, you reiterated that indeed, that, you know, various charities, including the one that you're associated with. What is it? Pedal for Prostate, is it?
Yes, it was an initiative started by one of our senior urology trainees. So that's the weekend of the 26th of September. And basically the plans, you know, have changed because of COVID now. So we can only do a virtual ride. So we've been very lucky. We've had virtual spin bikes donated to us. And we've got a lot of urologists that are very keen cyclists. So we're going to ride 1,000 kilometres. So it's Melbourne to Sydney, but virtually. And, you know, obviously, you know, each surgeon is competing against the other surgeon to raise as much money as they can. So I'd love to just show you the logo, actually, if I could, because it's absolutely, it's incorporating our love of prostate cancer and our passion for the prostate. But I'm just going to hold up the details there. So 26th, 27th of September, and the website is, so you can follow us on Instagram, Pedal for PCA, and the website is pumpthepedals.org. So if anyone wants to support Monash, we will be going to our research and also to our amazing prostate cancer nurses, and hopefully our biopsy ultrasound probes. But yeah, it's really exciting. We've got Brian Taylor hosting it, and a lot of support from Eddie Maguire. So yeah, hopefully it should be a good weekend.
Nice. The 26th of September.
That's right. Yes.
So we'll get that out there as well. So look, that's been great. Thank you again, Dr. Azer, and
pleasure.
Yeah, thank you. Very you know, informative too.
And well done, Phil, and Floyd as well for picking it up and uncovering it, I guess.
Yeah. Look, actually, I sort of mentioned that to Floyd in an email I sent him the other week about my fundraiser, that, you know, it was the best thing I ever did was to come to him.
Yes.
So,
Yes,
Yeah.
absolutely, absolutely. Not just the cancer, but that kidney stone as well. You know,
Yeah.
that would have just really affected your kidney function. And
Yeah.
it just goes to show, you know, it's such a simple scan, an ultrasound scan, and look how much info it gave you.
Yeah. Well, it was 35 millimeters, just for your information.
Wow, whoa,
Yeah.
backbreaking work. You would have, you made the urologist earn their keep that day.
Yeah.
Yeah. A lot of
Yeah.
breaking.
Oh, yeah.
So yeah, look, that's great, and so we might wrap it up there. But yeah, thanks again, Dr. Azer, and Phil, thanks for sharing your story.
And thank you for your pledge to